Day 3 of castlefest was a Justin Cook and Mike Stone kind of day. We did all things nerve blocks. We did an intro lecture. We did upper extremity, lower extremity, and plane blocks. Basically covered everything. Learned about the QL2 block, which is kind of interesting, and a suprainguinal fascial iliaca block, which I had no idea even existed. Check out this post-lecture interview that we did right after they talked.
If you're not good enough at ultrasound, that's not an excuse to punish your patients with radiation.
Get out there, ultrasound some hearts, some lungs, some IVCs. Let us know how you feel about it.
Yeah, we can definitely do that, or we could be better clinicians and use our ultrasound.
So we had day 3 of castlefest today, and Cook gave us some talks on musculoskeletal ultrasound with Mike and assistants, and Mike gave us some talks on nerve blocks with Cook and assistants. It was really a day of Justin and Mike pretty much all day long, with the exception of a short break with Malin. That was unacceptable and not unfounded. But it was awesome. You guys did some live scanning. We learned a little bit about nerve blocks. Actually, we learned a lot about nerve blocks. Learned a little bit about musculoskeletal ultrasound. What's your favorite nerve block, Mike, right now? Go.
Like favorite one that I actually do with regularity, or favorite one that I want to start doing more of? Both. Okay. Favorite one with regularity has got to be interscaling. I think you get a deltoid, big juicy deltoid abscess, and it's totally painless. It's awesome. It's the best.
What's another word for it than juicy?
Delicious.
What's
for the abscess? Large, generously sized, foul smelling.
How much are you injecting into those? I heard. So Cook told me something. I think it was yesterday. That blew my mind. He said he was only doing 5 cc's
for the interscalings.
C5, 5 cc. That's what you told me. Are you lying to me? You were lying to me, weren't you? I hate it when you lie to me.
I've done the smallest volume I've ever done for a deltoid abscess is about 5 to 7 mLs, targeted around C5 with 2% lidocaine. That's what we had at the time.
Yeah, you told me 5 mils around C5.
I misspoke.
You don't do that.
No, 10.
10. Okay.
So it's like a syringe, like a 10 cc.
Blows my mind. This is like very little lidocaine that you're injecting.
How much are you using?
And how are you focusing? Or I'm using like hundreds of mils. No, I'm not.
Dozens.
Safety interjection. He's kidding.
Safety interjection not actually happening. 15. But yeah. I'm also probably not as meticulous as you guys about like sticking it around C5. So what are you doing to localize your injection at C5? Is there anything
top one or the bottom one? Green light or red light? Sorry. Can you help me?
Red light.
Red light.
Top one.
Okay.
Yeah, top one. I think important to mention that it's like you're not trying to get a surgical block. Right. Again, this is why we don't need to do the whole interscaling breakout plexus if you know it's just deltoid territory. You could do it focused axillary nerve block, not an axillary approach to the brachial plexus block, but you could block the axillary nerve and get it that way, just sensation to the shoulder. But it's tough. It's a little bit hard for people to find the anatomy of like where that comes out behind the humerus. But
Herring's a big fan, but I find that is a little bit abstruse. Like that one's tough for me to find on a regular basis.
Yeah.
C5 is like, doesn't matter what your body habitus is.
It's a red light.
You're talking about the axillary nervous. Yeah. I've never tried to do that.
Yeah. Targeted axillary nerve. But if you go to Highland Ultrasound, look at axillary nerve block, or just Google axillary nerve block, not axillary brachial plexus block, but axillary nerve, just the peripheral nerve itself. It's a pretty cool block. It's very selective, less potential for adverse side effects. So it's cool, but it's more challenging, I think, technically. I think a interscaling block is a novice block for anesthesiologists. It's an entry-level gateway block. You need to know about the safety issues. You need to know about monitoring and about not getting into vessels. And there's all sorts of good technique around it, but it's not a challenging block. It's superficial. So C5, I'm just getting underneath the prevertebral fascia. So just the fascia that overlies the anterior and the middle scalenes and overlies the interscaling groove. So just popping a needle, typically in plane, posterior to anterior approach, through entering the prevertebral fascia, puncturing it right above the interscaling groove, or maybe just a little bit posterior above the middle scalene, and then moving the needle to the top of the interscaling groove above, superficial to C5, and then injecting.
Okay.
And it'll spread
around. You're not trying
C5.
to separate 5 and 6.
I'm not putting the needle between 5 and 6. I'm putting the needle above, superficial to C5. So this is literally, in most patients, like full-grown patients, 6 millimeters, 5 millimeters under the skin.
And realistically,
superficial.
That stuff's gonna drip down anyway, right?
Of course, yeah. It's going to spread to some extent. The advantage of doing like 5 to 7 mLs is the likelihood you're going to get phrenic from that when you're doing such a high targeted C5 is really low.
And did you say 2% Lido?
No, the smallest volume one I ever did was with 2% Lido because that's what we had, and 1% is a pretty weak anesthetic. I'd honestly like bupivacaine probably, or ropivacaine if you have it, is probably the best because that's going to hurt after you IND it.
Sure.
Right. It's not it's not like a shoulder dislocation where you just pop it back in and they're better. So I'd probably use bupi and I'd probably use 0.5% if I had bupivacaine, or 0.5% if I had ropivacaine, because you're not looking for this big dilute volume. You're giving just a tiny couple of ml. So toxicity is not an issue.
0.25%, just to clarify. Okay.
In the cadaver lab today, it's such a beautiful example of somebody just doing exactly that. I mean, right under the prevertebral fascia, like right on top of C5, and relatively low volume, and with a single needle placement, it really suffused the entire area around the nerve so elegantly, and it was just really delight to watch somebody who was new to this whole thing, big smile on their face, like, oh, I can do this.
It's not that challenging. It's all activation energy with blocks. It's all activation energy with blocks. Thanks for directing the microphone towards my face. I mean, like, we've talked about this before. I think it's so much harder to place a radial arterial line with ultrasound guidance than it is, or to put in a tough.
I mean, let's be honest. A radial arterial line is like one of the hardest ultrasound procedures.
Fine,
right?
or to do a peripheral IV with.
I think peripheral IVs are the hardest.
I think that's harder
procedures.
than doing an interscaling nerve block. I feel like finding a foreign body is harder. Like doing tendon ultrasound of the shoulder is harder. Like,
paracentesis is easier. Thoracentesis is easier. I think
because you don't even need the ultrasound, really, right? Like, I mean, it doesn't really matter if you lose tip of the needle. You're still going to get into the right spot, pretty much. Not that we advise that,
unless you get into the lung.
Yeah, that's the bad spot.
Generally thought to be bad.
Not a good place.
So they
It's
say.
crazy that, a serratus is technically a much easier procedure than an IJ by such a huge margin.
Yeah, that's true.
Most blocks, you've got this huge room for error in the sense that, kind of anesthetic spreads along fascial planes. So if you don't hit the exact target, it's going to spread towards the target. As long as you don't get into the thoracic cavity or the abdominal cavity or a big artery or do an unrecognized intravascular injection.
And also,
it's pretty hard to
not only that, worst case scenario, assuming there isn't, you don't poke something you're not supposed to poke, is it doesn't work. And then
that's the worst case.
And then you do the thing you were going to do otherwise, right?
Although, like, frankly, between the four of us guys, how many blocks have you tried where it didn't work at all?
I mean, not
like it wasn't surgical, not like it wasn't profound, but like you just had no effect.
None.
Maybe a couple.
So
maybe
rare.
a couple.
Maybe right when you started and you were like worried about using too much anesthetic.
Yeah, or I do a new one, or I don't wait long enough. I mean, I think most of the time that it didn't work was just because I didn't wait long enough to be
There are occasional people who are totally refractory to local anesthetics, though.
Really?
Kind of freaky. Have you ever seen one of these people?
No, that would be really unfortunate.
Yeah.
So
Imagine
going to the dentist.
Once you guys digital blocks on it, you're like, dude, I put 10 cc's in your finger. Like, there's no way you can't be numb.
Once you guys push past 40, you'll probably start seeing some of those patients when you have a little bit more experience, like Justin and I. No, I remember I did a digital block on this guy. I redid a digital block, and then I was like, screw this, man. Ultrasound-guided median nerve block, and still nothing. And I double checked, like, was I using expired anesthetic?
So you gave the guy propofol to reduce his finger.
No, I gave him lipid emulsion because I made him toxic with all this.
Because you blocked him so many times because it has to work.
Well, I just outlasted him. Ultimately, he was like, just put some stitches in a dog. Yeah.
Well, yeah. I mean, you poke him enough times. Right. At some point, like it's shorter to just do the stitches, right?
It was not my proudest.
Some topical, like some let.
But apparently, that's out there. That happens.
What should we talk about musculoskeletal ultrasound? What are the take homes?
It's a really, really fun thing to teach on a lecture-based format. I think that's the big take home.
I think it is fun to teach. I think it's that awesome like game of show and tell, right? I mean, like you see if anybody's got something they want to show off, and then they come up on the stage and you kind of show them how to do it. It's one of those. It's so dynamic. It is the worst possible lecture to give with slides, I think. After nerve blocks.
Well, because you need to show, like, because a lot of it's like manipulation, like you have to actually like move the shoulder around. Is that what you mean?
Yeah, I mean, otherwise you're just showing all these images of like how to put a probe on skin, when realistically you should just be doing that with an ultrasound machine.
Frankly, at core, I think the beauty of MSK is, like, more so than other ultrasound diagnostic things that we do, it is the thing to learn on yourself, right? I mean, if you have limitless time with a transducer at your house, just
lots of gel.
Look again, and then compare it with an anatomy reference, and just try and get a picture of it in your mind in as many different planes as you possibly can. And then all of a sudden things start to create a picture, at least in my sort of way of constructing 3D images in my very simple brain. Like, that for me is when it actually starts having
Justin,
value.
you had a great acronym today, and I love acronyms. Unfortunately, I can't remember it. Can you remind me what it was?
Not sure which one was it.
It was CAPD.
Oh, CAPD. Yeah.
Or
right.
PAD C. Yeah. So P for positioning, right? So you want to make sure that you're optimizing the patient's position to try and look at the structure in question, right? So somebody with a knee in full extension versus a little bit of flexion is actually going to highlight, say, their effusion differently.
Nice.
And A for anisotropy. So that's the A in CAPD. And so you want to toggle the transducer to try and get the structure in question as perpendicular to the beam of the ultrasound as possible, because that gives you the least amount of artifact and the truest representation of the structure. And then P is, we were CAPD. Let's start with compare.
Okay.
So C is compare the other side to the affected side for reference. And then D is, it's a dynamic exam. So particularly when you're looking at tendons, which could be injured, partial injury versus a complete injury can be discerned by actually putting some dynamic movement into the process and seeing what the joint looks like under stress or with.
Mike Stone, if you had to order those in order of most important to least important, how would you do so?
Oh man, well you can't run into one of Cook's acronyms and try and prioritize. They're all important. I was gonna say I've traditionally been somewhat of an MSK. I can't say like hater, but I've just like questioned the general application in my clinical practice as an ED doc of like, is this a supraspinatus tear versus an infraspinatus tear? Is this like, a partial tear versus a complete tear?
And realize that.
And then I tore everything. No. But I would say that like the what I love about MSK is there are two things I love about it. One is the dynamic aspect of it, because even MRI, which is the holy grail of musculoskeletal imaging, you can't look at what happens with an impingement syndrome. And there are like actual things you can diagnose dynamically with musculoskeletal ultrasound that you can't get any other way. I think that's so cool. And then number two, you take novices who have just rudimentary procedural skill and comfort and show them how to get into all these joints that they otherwise would never go for, right?
Totally
so
true.
like elbow, ankle, wrist, even just those where like, or shoulder, where people are like, oh no, I got to call orthopedics or interventional radiology to do that. And all of a sudden they're like, wait a minute, I could do shoulders and hips and wrists and ankles. And it's just finding the joint space and putting a needle in. And I know how to do both of those things now. And those are not technically challenging. Right?
I think that for me, it's the joints for sure. I mean, like that was the thing where I was like, man, MSK is totally applicable in emergency medicine and acute care medicine.
We had a family practice doc today who was I'm going to go back to the office and just practice on my wrist and my elbow and my ankle for like the beginning of my shifts for the next 2 weeks. And then I feel like I'm going to be able to put a needle into any of those joints. I'm not going to refer these people out or send them to the ER or anything else. And I was like,
you take something like a wrist, which is just so hard to get to aspirate without just like torturing somebody, right? Mm-hmm. And all of a sudden you make it like ridiculously easy.
Yeah, you still only get like 0.7 mLs out of it, right? That's why it's so hard. But you know that you got it, even though it looks big.
And you don't poke their cartilage a ton of times. It's not, you don't get frank blood like you used to. Like there's just so much. It just changes.
We're going on the bottom of the wrist, Mike?
It's a radial artery tap.
Towards the size.
Biopsy. Radial artery biopsy. You want to say anything else?
You didn't ask me about the block that I really wanted to start doing though.
Yeah. We weren't going to actually. No, I don't actually care.
Okay.
Actually,
all right. I'll keep it a secret till next year.
Hey, Mike.
That's all right. Yeah.
What block would you really like to do more?
Oh my God. Thank you so much for asking. I was really hoping you would.
All right. Well, thanks for listening, guys.
It's been great.
Have a good day.
Bye, y'all. I just had the chance to hang out with Nadia Hernandez, who's a anesthesiologist out of Memorial Hermann in Houston, who's a dynamo and a regional anesthesia ninja, and she was talking about QL2 blocks, so quadratus lumborum 2. It sounds like there's at least 3 quadratus lumborum blocks. But the 2 is the posterior one that seemed safest and most accessible to me, but it's basically like a real lateral tap block. Transversus abdominis plane block.
Okay.
But instead of getting just the somatic abdominal wall, you get visceral.
Oh my gosh.
So you could do renal colic.
So are you coming back?
Could you block for renal colic?
All those patients with like
refractory abdominal pain.
Yeah. I'm just like, just quit complaining about your appendicitis.
Totally. You should go home now. That doesn't hurt anymore. I'm sure there's nothing wrong with
all those pesky right lower quadrant pain patients.
But I think for renal colic, I haven't, and I'm like really. I just said this is the one I'm excited to do. I haven't done it, but it sounds like if you could take. I feel like there's other than like chest wall pain from rib fractures, the only other thing we see commonly in the ED where like the dispo and the time to dispo depends almost entirely on symptoms is renal colic. right? If you've got really bad abdominal pain, you're coming into the hospital. Maybe I need to image you to see whether you need to have a surgery or not.
So you're really getting retroperitoneal block there? I mean,
It's retroperitoneal. Yeah, but it's not that, when you see how close it is to the tap, you're like, oh, that isn't actually that far from where I was going anyway. And there's nuance to it, and like I need to read more about it and learn a little bit more, I think. But I think for that sort of, you'd otherwise send home afebrile, not solitary kidney, the hemodynamically fine.
Toradol didn't do it.
Yeah, Toradol didn't do it. You gave a dose of opioids, and then you bit the bullet and for some reason got a CT, even though you already knew what you were seeing on ultrasound, because you're like, maybe there's something I'm missing because they're still so uncomfortable. And then the CT gets done, and now you're 3.5 hours in, and they've gotten multiple meds and a CT, and they're still in pain. It's 11 at night, but it's their first day, so you don't really want to call the urologist and admit. I think it's it'd be worth trying.
I use ketamine in those cases.
Yeah, it works too.
Yeah, it works really well.
And then 10 minutes later, they see one of your other colleagues after you change shift. When the ketamine wears off.
Except for the ketamine just resets everything, and their depression goes away, and
now it doesn't hurt anymore.
They leave happy and never come back to the emergency
They
room.
forgot why they were there.
Psychogenic renal colic.
So I can't believe that we've gone this far into this little podcast, and the bombshell of this day has not been addressed yet. The suprainguinal.
Oh, yeah.
To the fascia iliaca.
I think we've gone over for time though, so yeah, it's not that important.
You know what, Mike? We'll fit you in. It's okay.
No. I think we should talk about anything else, really. Now, I again, I think that if you ask the insufferable, ultrasound fellow new attending me about learning, super insufferable, about learning techniques from people who weren't emergency physicians, I'd be sort of tribalistic and like, well, what do they know? It's not like we have different needs and different, our environment's different and yada, 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 a lot of which is true. But talking with anesthesiology folks who I respect, this is a really cool block, and it's just a different approach to something I'm doing already, but it seems like it's probably a little bit more effective. So just going kind of medial to the anterior superior iliac spine at the little bow tie where the internal oblique and the sartorius come together above the iliacus muscle, and just doing a fascia iliaca compartment block there. It's a little bit of a different approach. It's not new. It's been around for a while, but I think I was successfully convinced that it's a better way to go than just routinely.
Why is it better?
I think your anesthesia is a little bit higher. And it's a tricky part of the body to get numb because the innervation to the hip is complex. And anything that's a little bit more proximal is probably going to get you a little bit better result.
So it's like going to get like more sciatic? Like what
no,
is it?
I think you're just you're probably gonna, if I blocked your femoral nerve at the mid thigh and you had a proximal third femur fracture, it's not going to do a whole lot for you. I think if you're doing a fascia iliaca compartment block a little higher, you're just going to get a little bit more proximal analgesia, certainly over the skin incision, over the area where you do like a pin, but that's not really the issue for us. But I think it's just going to work a little bit better.
Where would our listeners go if they want to learn about that suprainguinal fascia iliaca block?
I mean, current resources, other than like the Twitters and the YouTubes, I'd probably go to...
you mean at Bedside Sono? Is that what you're saying?
Yeah, there might be some Twitter DM stuff you could do, but if I wanted to read more about it, I'd probably go to some of the good free open access regional anesthesia sites like New York School of Regional Anesthesia, NYSORA, or ASRA, American Society for Regional Anesthesia, or usra.ca. If that's still up, I haven't checked recently, but ultrasound-guided regional anesthesia Canadian site that Vincent Chan started. And honestly, the Googles, SIFIB, suprainguinal fascia iliaca block, or just spell it out and search for it. You'll find videos and there's some literature on it. And
sounds awesome.
Back to Google one, do one, tweet one.
Ultimately, I think if you have the core basic like safety and monitoring principles and like pharmacokinetics and treatment of complications down, that's one of the things that made me fall in love with regional anesthesia is you could just learn a new block.
Yeah.
Learn what sort of specific considerations there are, but most of them are the same ones for all of the blocks. And then try a new block.
Favorite pearl of the day, guys. I'm going to go with mine first since I suggested the question. Mine was, as you're trying to get through that little fascial layer, you do that little twist.
Yeah, that's huge.
I learned that from Nadia. That's a shout out to Nadia Hernandez. She taught me that. I said, how do I end up not puncturing into the muscle under the fascia?
Does that work with a non-cutting needle?
It does work with a non-cutting needle. And what's funny is I have used that a couple of times to swing that pearl back to another application that I know they don't do on the anesthesia side is, when you're doing a vascular procedure and you want to get into a vein and you tent the superficial wall against the posterior wall and then you pop through and hopefully you're in, but maybe you're all the way through. Right. So you can like try a jab and see if that works to get in.
Or tension.
That happens in big joints. So in hips, the same thing happens where you take the superficial aspect of the synovium and you kind of tent it against the deep aspect of the synovium. And then you've got synovium bone, and you can't pop through. Like it won't go through. It's really frustrating. You've got like a hip tap and you're like, oh my God, there's the fluid and I can't get anything out. And it's so frustrating. I like worked up the gall to do a hip tap and I can't get anything. Twisting, which I didn't even think about putting the two together, but in the past that has worked where you're right on the superficial synovium and you just twist a little bit to bore through it and it pops in and you get your fluid out. It's cool.
Nice.
It's just like dilating for a central line.
That's a great tip.
Mm-hmm.
Yeah.
Right? It's like when you're dilating, it's a twist and push, and like why we didn't just.
What a phenomenal tip.
Super cool.
I wonder. I wonder if that would work with PIV as well.
Somebody asked me that today.
Really?
They said, I wonder if that would work for peripheral IVs.
So there's that PEDS peripheral IV by ultrasound study that talks about leading edge of the bevel. Like
bevel up, bevel down. This guy talks about bevel down. I learned that from him. Bevel down's better.
Well, I learned it from him.
Is it better because, well, that's because he gives the best vascular access of all time.
Absolutely.
But bevel down is better because you get flash when more of the catheter's in.
No,
is that what you think?
The stabby end is not going through the right. The stabby end is not going through that posterior wall
because your stabby end and your
less stabby end,
less stabby end of the bevel go through to about the
Tends to go so flat
because you're hitting it at an angle.
Gotcha.
Right? So you're less likely to go through the back wall.
So it's all about the stabby end.
I think,
the stabby end.
I think also like the pressure is made more proximal on the vein by the stabby end in that case, which I think I love the fact that we're still saying stabby end after.
Are you kidding? Have
But
you
everybody
heard
knows what that
aortic
means,
dissection
right?
talk?
What else
What
would
do you
we
call
say?
the
Tip
thing
of
in
the
the
bevel.
aorta when you see it?
It's the flappy thing.
It's the flappy thing. An entire
Stabby,
talk where
flappy
all he
thing.
says is the flappy thing.
But is
Stabby end and flappy thing.
is that
I know
not what
you
it is?
meant. I
Is
know
that
what you
not what
meant.
it is?
It was the
Yeah.
flappy thing.
the flappy end?
All right, but
So-
bevel down, like we should definitely start doing bevel down more. What would it help for peripheral IVs though?
Well, maybe-
the twisting.
Well, maybe it'll help it not tent, right?
Not
When you're
tenting?
having tenting,
Yeah.
right? I mean, like I see some pretty significant tenting, especially if you've got low volume patients. So hypovolemic patients, you're trying to get a peripheral IV in. You know, I mean, tons of tenting, right? Even if you've got a tourniquet on.
Yeah.
So in those people, I try to bring some some distal pressure on the skin, retract the skin a little bit. You got all these techniques, but it might help to actually twist a little bit.
I do
gonna
double
try that.
tourniquet.
As soon as
That's
you
the
get the
thing I've
tenting.
tried. It's like distal proximal
Interesting.
when
Okay.
it's tenting too
I like
much.
that,
But I've
yeah.
never tried boring. I think that's
At
next
what
time.
point do you start boring though? Do you do it right as you
As you're touching the wall, probably. Yeah, I think
As
so.
you see tenting, as soon as you see a little tent, you could give
Just
it
a
a
little
little
twisties.
twist.
Just a little twisty with the sharpie pokey until you see a flappy on the inside, and then you're there.
I think it'd be great for radial art lines.
I think you're right. Yeah.
It could be.
Or
yeah.
fem or pop.
Pop up. That's my favorite.
I feel like now's a good time to stop.
Yeah.
I feel like 20 minutes ago was a good time to stop, but that's cool.
We've been recording 23 minutes. So
23 minutes.
For sure, 20 minutes was
Could
the
we
right
keep
time.
going? I feel like the
Let's just
pearls-
talk.
But you know what's
They just keep
awesome?
coming
though?
out.
It's like it's almost like the first 21 minutes were worthless, and then we got to the pearls, which would have been the best part so far.
Yeah.
I mean, sure. Yeah. What was your favorite thing you learned today, Mike?
I didn't learn anything.
Yeah, well, obviously.
I learned that Mike he still lectures occasionally. I did not know that.
yeah,
That was
yeah.
my
I
biggest
saw him on the
professor.
stage.
Mike gave a lecture today.
I almost called security because I was like, who's that guy?
Who's this man?
Only when forced.
All right, I want to tell one
That
quick
was a solid
story.
pickup
Maybe
on
this will
the
get us out of the woods. And I'm not going to name the person except to say that they're a former Ultrasound Leadership Academy fellow. So former ULA fellow today told me a story about his first erector spinae plane block. So for a brief review, right, ESP block from a posterior approach, maybe T4-ish, put a needle on the transverse process and inject a bunch of anesthetic, 40 mLs of dilute anesthetic, and lift the erector spinae off of the transverse process. Really hemithoracic pain. So rib fractures are the classic. People are using it for a whole host of other things. I haven't had a ton of success trying things outside of rib fractures, but I hear musculoskeletal back pain all the way through to surgical indications. But for the random sort of general emergency physician, I think rib fractures is where you're going with it. Maybe more posterior ones as opposed to lateral. So he had a patient come in, transferred to his center on non-invasive positive pressure ventilation, CO2 narcotic, like with a carbon dioxide in like the 70s or 80s, on non-invasive, obtunded a little bit, in pain because of a bunch of rib fractures. So it got sent to him because they weren't breathing very well, so they were hypoxic, they got pain meds, etc., spiral of doom, and was like showing up, hypercarbic respiratory failure.
I want to just like guess what happened. I think I know what happened.
So tell me what happened.
What happened is he did an erector spinae block,
His first after Googling.
and the guy did so well he ended up off of the vent.
in 20 minutes was off of non-invasive positive pressure ventilation and literally drew another gas. He works outside of the U.S. They don't do secondary testing for any reason whatsoever, and drew another gas just out of curiosity to see what had happened to the CO2, and the CO2 had like dropped back down to normal.
Oh, that's amazing.
And the patient had said,
minutes.
"Wow, I can breathe again.
That
Thank
is
you. I
so
feel so
awesome.
good."
That's a way good story.
What a great story.
It's an easy block. It's easy to do.
Googled it. He was like,
Just
"That's the first
Google
one.
it.
I just Googled it. I watched it. I saw like this
Google
one
it a
reference.
little.
I saw this one talk, and I just went and did it."
That's amazing. What a great story.
And then the patient was like, I'm cool with consenting now.
Yeah, no, then he discharged the patient, and the block wore off. No,
And then the guy came back in
no,
4 hours.
he actually had. It sounded like a real success. And I mean, listen, we're all like about the most sarcastic people out there in the world, but and jaded and hardened and all of that horrible emed stuff that it does to us. But like hearing these stories here for me has been pretty awesome, and they're not obviously they're not about all like nerve blocks. They're about all sorts of, hey, I used ultrasound and I did this thing and I never would have done it, and then I listened to this or I saw this or I took this course, and it's easy, I think, for us to lose sight of like patients are the ones ultimately who are like getting a benefit.
The day 4 summary is coming up pretty soon. In the meantime, if you like what you're hearing and want to come to one of our conferences, our next one is in July of 2019, and that is in beautiful Bend, Oregon. Hit up benfest19.com to learn more.